Good afternoon. My name is Joyce Rakes, and I'm the Nursing Quality Facilitator at Korean-Roanoke Memorial Hospital, and serving as moderator today for our oral presentations. We have 5 presenters today, or 5 groups, and they're on a 15-minute time limit, so we just want to welcome you all, and we're really excited about them being here. Our first presenters are Cecile, Dietrich, and Chandler. They're staff nurses here at Roanoke Memorial Hospital, and they're going to be doing a presentation on pilot of a sedation scale for monitoring opioid-induced sedation.
First. Hi everyone. Wait. Today we're doing a presentation on a pilot study that we did. We retitled it Bridging the Gap for Measurement of Unintended Sedation. In this presentation I hope to address the following points. That first of all, the problem of unintended sedation, the action of the Pain Council in addressing unintended sedation. We want to introduce the Pissarro and opioid-induced sedation scale and review the results of our pilot study that the sedation subcommittee conducted. This is our biggest, what we saw as a very big problem. Obviously, we're all nurses here, so we know that sedation that advances into respiratory depression is a problem. Advancing sedation leads to respiratory depression, and if we don't intervene, respiratory depression can eventually lead to death. So we know this. The solution is prevention, and that is what we hope to do in our assessment of sedation. Do we currently have sedation scales in our hospital? Yes, we do. We have the University of Michigan scale for children, the Richmond Agitation and Sedation Scale. These are both reliable and valid scales, but they are reliable and valid for intentional sedation, not unintentional sedation. So what we've done is to introduce this new scale. We didn't create this scale. It was created by Chris Pissarro, and it is the Pissarro Opioid-Induced Sedation Scale. The main advantage this scale has over the Michigan scale and the Ross is that it was designed to address unintended sedation, and it's valid and reliable for that purpose. Okay. We'll get to the PAWS in a little bit more detail in a subsequent slide. So these were the actions of the Pain Council. First, we formed a sedation subcommittee to examine our problem. We then initiated a quality improvement study on how to best integrate the PAWS sedation into our current sedation assessment practice, because we're not doing away with the Ross and the Michigan scale. This is something that we're doing in addition to address unintended sedation. We then implemented a dissemination plan based on the results of our quality improvement study. This slide gives a little bit of a background on respiratory depression. Respiratory depression is an insidious process. It creeps up on you and on your patient. And if you're going into a room and looking at your patient, and if they've taken opioids, if they've taken anxiolytics, they look like they're resting and sleeping and peaceful. And so, I don't know about you, but I've been in rooms, I look at the patient, they look asleep, you see their chest rise and fall, and then you leave. So you don't think that there's anything wrong. You might decide that you want to check the patient's pulse oximeter reading. And if they're on supplemental oxygen, that could be falsely elevated. There are many risk factors for respiratory depression. If you look at this list, and I'm just going to give you a moment to look at this list, there are several factors. If the patients just had surgery, if they're very young or if they're very old, many patients are not at risk for respiratory depression? That's another way of looking at it. So monitoring a patient becomes critical to keeping them safe. That's the bottom line.
Okay, so we've introduced the POS, which I believe is now implemented as of May 1st at Carilion. And who should use the POS? So basically the question is, do we want the patient to be sedated? Yes or no? Basically, if the patient is in, for example, if the patient's in an ICU and they're intubated, then the question is, yes, you do want them sedated, so you would use the RAS. And the POS has not been introduced in the adult ICUs as of yet. Also, if they're in pediatric ICU and you want them to be sedated, you would also use the Michigan sedation scale. But if you just want them, if you're just giving for pain control, so if you do not want the patient to be sedated, then that's when you would use the POS. And that would be the appropriate scale. I think we've given everyone a copy of the POS. So it's real important in the first, when you give a pain medicine, whether it's an opioid, any type of pain medicine, to wake them up, which we know a lot of nurses don't, but it's very important to wake them up because due to, as Cecile pointed out, the sedation issues and respiratory issues. So you need to wake them up. If they are, in the S1 or 2, when you do wake them up, that is acceptable, and you don't have to do any further actions. If they are really drowsy, they do wake up, but frequently drowsy and maybe fall back to sleep, that is unacceptable, and it gives you guidelines to follow, but these are not orders. We would still have to call the physician as well to get orders, but these are guidelines that the nurse can talk to the physician about. And then number 4, if you are totally unable to wake them up, obviously that's very unacceptable. You might consider calling a rapid response, or discussing with the physician or LIP, for giving Narcan and other orders. The pilot study. We did the pilot study for the POS on 8 different units. On 8 units, there were 315 sedation assessments done. At the end of the pilot, we had 25 nurses. They all reported the education was helpful. Only 8% reported difficulty choosing between the 2 scales, unintentional or intentional. Specialty-specific suggestions included more guidance with mechanically ventilated patient populations or pediatric-specific training. And we have already had POS super user class, so hopefully that will help as well. And basically, our findings support an effective process to improve our current practice for sedation and assessment tool for selection. Demonstrated organizational change based on identification and implementation of best practices by a committee, our committee of the pain resource nurses. So we developed and executed the plan to disseminate the POS across the units, which has now been done, all except for the adult ICUs. Questions?
Any questions about the scale or?
How did you get nurses from the other units to buy?
Well, we did this by utilizing the pain resource nurses. Every unit has at least one pain resource nurse. So that nurse was responsible for recruiting other nurses to help pilot. That was basically
to help come maybe possibly go to super user class. There's also education on Cornerstone. So we will be monitoring this for a long time to make sure they are using it.
Once you have this monthly unit is amazing. Really, that's amazing. You can see how much you have invested.
Yeah. So that was our main recruitment strategy. And then anyone that helped help pilot the study, we invited them to the pain council meetings. Not all, some of them went, you know.
So I think it's just going to take time, and we will probably start seeing it, next Sunday, with our computer-generated pain assessment reports, and go from there. Any other questions?
I just wanted to ask a question, maybe Dr. Go ahead, about the reassessment, pain reassessment and patient reassessment. Are we going to develop a new assessment tool?
To the POS.
Yes.
Yes.
Is that a yes?
Yes.
Okay.
Repeat
And
the
then
question,
the
please.
monitoring for follow-up, like we have the report every week for the RAS.
It's, we have the weekly reassessment that comes out, and I've spoken to David Bowers to add the cost as part of that. So whether it's pediatric or adult, then it would be either or the RAS or the Michigan. What we need to develop is a quality improvement to determine the correct tool to use. So, you know, that the report doesn't think, it just knows if it's there.
Because as of today, when one element of the RAS is at rest in reassessment and not all the elements, it comes up as red. So I don't know if that's going to cause a little bit of an issue when some nurses choose either or both.
It's going to give the credit to compliance of either or. It doesn't think about did they use the right cap or the right sedation. So it's not going to penalize. That's why we're going to have to work on ongoing quality to ensure that the correct sedation scale was used.
But my staff learned it. I just wanted to know that they have between the two, the RAS and the constant, so